السلام عليكم ورحمة الله وبركاته. I am Dr. Hayam Fathy عبد الحي غازي, Assistant Professor of Medical Oncology, Mansoura University. Have new studying year. You start clinical part of medicine. Today, inshallah, we discuss very important section in hematology, which is physical examination of hematology. And this information included in this presentation are not the only source for this topic, and you should explore other valuable references in order to satisfy the ILOs of this topic. This slide showing how to contact with me to discuss me, to question me or discuss me any difficult topics. How about this ILOs of this lecture? Identify role of general examination in diagnosis of hematological diseases. Identify role of skin examination in diagnosis of hematological diseases. And identify role of abdominal examination in diagnosis of hematological diseases. Identify role of chest examination in diagnosis of hematological diseases. Also identify role of neurological examination in diagnosis of hematological diseases. Identify role of lymph node examination in diagnosis of hematological diseases. And identify the differential diagnosis of splenomegaly, hepatomegaly, and lymphadenopathy of cases either in medicine or hematological diseases. First of all, during physical examination, you must arrange these roles during examination and prepare yourself for clinical examination. Reflect on your approach to the patient, adjust the lighting and the environment, check the equipment, for example, thermometer or sphygmomanometer, make the patient comfortable, and choose the sequence of the examination. A mnemonic for starting physical examination, which concluded in this abbreviation, which is WIPER. Wash hand before and after examination. Warm your hand, especially in cold weather. Introduce yourself to the patient. Permission from the patient to examine them before examination. Must be put the patient in a comfortable position to avoid irritability, and you can examine patient perfectly. Expose the patient as needed, and cover the patient during examination, and to maintain patient dignity. You must be on right side of the patient except some positions during the examination. For example, thyroid examination, you must behind the patient. Firstly, general overview, the appearance of the patient. From the first look, the patient appears ill or appears well. Appears ill, it is patient healthy, okay? As this figure showing this patient is appears ill and this patient is appear well. Belt examination showing skeletal configuration, height and span to detect if there is abnormality. So the doctor must be good observer from the start. Complexion, it is reflection, refer to the color and the appearance of the skin. Consciousness, either the patient conscious to oriented to time and place and person. Decubitus refer to the observed posture which the patient in bed, and preferred posture when the patient in bed. Gait refer to way or manner of walking of this patient. And this figure showing A and BC showing the normal and abnormal person, either kyphosis and lordosis and port belly or obese or abdomen is enlarged, okay. And this showing masculine person, and this very morbid obesity, and this tall patient, tall person and this short person and this obese and this thin patient. How about the cubitus? This patient is orthotic, especially in cases of mediastinal syndrome or congestive heart failure, and this patient leaning forward to avoid pain, especially in acute pancreatitis or pancreatic carcinoma, for example. And this gait showing this patient circumduction gait in cases of hemiplegia. How about complexion? Pallor and flushing. The color of the skin is caused by the pigment contained and by the blood flowing through the skin capillaries. The component of the skin color related to the blood may be a useful guide to anemia or polycythemia because pallor may result when the hemoglobin level is reduced and redness when the hemoglobin level is increased. Alteration in blood flow and in hemoglobin content may change skin color. This may mislead the clinician. Thus, emotion and exposure of the skin to cold or heat may cause either pallor or flushing, but not indicate anemia. So, chronic exposure to wind or sun may lead to permanent redness of the skin and chronic ingestion of alcohol to a flushed face. The degree of erythema of the skin can be evaluated by pressing the thumb firmly against the skin. For example, on the forehead, so that the capillaries are emptied, and comparing the color of the compressed spot with the surrounding skin immediately after the thumb is removed. The mucous membrane and nail bed are usually more reliable guide to anemia or polycythemia than the skin. The conjunctiva and the gums may be inflamed and not reflect the hemoglobin level, or the gums may appear pale because of pressure from the lips, and the gums and the nail beds may also be pigmented and the capillaries obscure. In some individuals, the color of the capillaries doesn't become fully visible through the nails unless pressure is applied to the fingertip, either laterally or on the end of the nail. The palmar creases are useful guide to the hemoglobin level and appear pink in the fully opened hand unless the hemoglobin is 7 gram per deciliter or less. Liver disease may induce flushing of the thenar and hypothenar eminence of the palm, even in patients with anemia. This sign called palmar erythema. This figure showing palpebral conjunctiva, which showing pallor in this palpebral conjunctiva. Jaundice is the second item in complexion. Jaundice may be observed in the skin of the individuals who are not otherwise deeply pigmented or in the sclerae or the mucous membrane. The patient should be examined in daylight rather than under incandescent or fluorescent light because the yellow color of the latter may mask the yellow color of the patient. Cyanosis, the detection of cyanosis, like the detection of pallor, may be made by skin pigmentation. Cyanosis is a function of a total amount of reduced hemoglobin, methemoglobin, or sulfhemoglobin. The minimum amount of these pigment that cause detectable cyanosis are about 5 gram per deciliter blood of reduced hemoglobin, 1.5 to 2 gram per deciliter of methemoglobin, and 0.5 gram per deciliter of sulfhemoglobin. Vital signs in the form of pulse, blood pressure, temperature, respiratory rate. This figure showing a collapsing pulse, which is normal pulse, and this water hammer pulse, which is present. This picture showing the water hammer pulse in cases of hyperdynamic circulation in severe anemia and hyperthyroidism, and this showing fever pattern. This continuous fever in the day through the day through the day, it is high fever, lobar pneumonia, typhoid, urinary tract infection, and brucellosis. And this intermittent fever in malaria and diarrhea and septicemia, and this period of afebrile in the first day and in the first time of the day and this last time of the day, and so through daylight it is high fever, remittent fever, it is fluctuating between afebrile and febrile, and this relapsing fever, Bill-Epstein fever, it is characteristic for Hodgkin lymphoma, is days febrile and days afebrile, and this mouse examination in cases of hematological diseases, ulceration, purpura, gum bleeding, gum infiltration, and the state of the teeth. This it is a clue to diagnose the hematological disease. Ulceration, for example, it is immune compromised patient in cases of megaloblastic anemias or leukemias. Purpura in cases of thrombocytopenia and bleeding tendency in cases of immune thrombocytopenia and leukemias. Gum bleeding in cases of bleeding disorders, for example, immune thrombocytopenia, and in causes also in leukemia. Gum infiltration in cases of leukemia and patient presented with gum hypertrophy, and the state of the patient teeth give me source about knowledge about causes of this abnormality in this patient. For example, bleeding lead to and smoking lead to blackness of the teeth. And this figure showing angular glossitis in cases of immune compromisation and vitamin B12 deficiency. And this figure showing gum hypertrophy in cases of acute leukemias, especially M4-5. And this lip showing bleeding in the lower lip in cases of immune thrombocytopenia and leukemia. And this, according to eye examination, ophthalmoscopic examination, is also essential in patients with hematologic disease. Retinal hemorrhages and exudate occur in patients with severe anemia and thrombocytopenia. These hemorrhages are usually the typical flame-shaped hemorrhage, but they may be quite large, elevate elevate the retina so that they may appear as darkly colored tumor. Round hemorrhage with white centers are also often seen. Dilatation of the veins may be seen in polycythemia in patients with macroglobulinemia. The veins are engorged and segmented, resembling link sausage. Upper and lower limb examination in hematological diseases. Hand and nail may show features associated with hematological abnormalities. For example, koilonychia in chronic iron deficiency anemia is rarely seen nowadays. This figure showing chronic iron deficiency anemia and nail changes in the form of loss of luster, longitudinal ridges, may become brittle, fragile, may be flat or even spoon-shaped, koilonychia. Edema, it is excessive build-up of fluid in the tissue. This either occurs throughout the body, generalized swelling, it's called anasarca, or limited to specific part of the body, it is called localized swelling in the, for example, in lower limb, in the abdomen, in the upper limb. It can be either beating or non-beating edema according to this figure. Either beating edema in cases of severe anemia or chronic liver failure, chronic heart failure, or chronic renal failure, and this non-beating edema in cases of lymphedema, in cases of obstruction by masses or lymph node in lower limb, in cases of huge lymphadenopathy, inguinal lymphadenopathy, or in upper limb in huge axillary lymphadenopathy. According to bones and joint, recording of bone, joint swelling and ranges of movement are standard aspect of hemophilia care. In myeloma, areas of bony tenderness and deformity are commonly present. This figure shows joint bleeding in cases of hemophilia, this superficial ecchymosis, and this showing hemoarthrosis. As regards skin examination, subcutaneous hemorrhage, it is mean bleeding into the skin and subcutaneous tissues. According to the size of this bleeding, it may be small in petechiae when less than 2 millimeter, and this show in this beside figure, and purpura from 3 to 5 millimeter, ecchymosis more than 5 millimeter. The hematoma is a large collection that form a lump. Petechiae and purpura are small, round, red or brown lesions resulting from hemorrhage into the skin and are present primarily in areas with high venous pressure, such as the lower extremities. These lesions don't plunge on pressure, and this can be demonstrated by compressing the skin with a glass microscope slide or magnifying lens. Purpura may occasionally be elevated slightly palpable. This finding suggests vasculitis. It is called vascular purpura, as figure in the next slide. Ecchymosis may be of various sizes and shape and may be red, purple, blue, or yellowish as seen in this figure, depending on the intensity of the skin hemorrhage and its edges. The lesion of the hereditary hemorrhagic telangiectasia, it is one of benign hematological diseases, are small, flat, non-pulsatile, and violaceous. They plunge with pressure. This figure showing purpura up to 5 millimeter, and this purpuric eruption in the lower extremities, the most dependent areas, and this collection of purpura and petechiae and purpura and bleeding in the lips and hemoarthrosis in case of hemophilia, and this ecchymosis, and this showing vascular purpura which is elevated on the surface. Nodules and scar and hair. Pay attention to the patient of distribution and texture of hair over the body. Sparse or coarse in hypothyroidism. Hypothyroidism lead to sparse hair. Chemotherapy lead to alopecia and diminished of hair. Increased hair in cases of Cushing disease and Cushingoid syndrome and neoplastic condition which lead to paraneoplastic syndrome. Nodules, scar, and hair. Subcutaneous nodules are solid, raised bump on the skin. Scar tissue form a skin heal after an injury or surgery. This keloid, this figure showing this keloid, is an abnormal scar that is thicker, different color and texture extend beyond the edge of the wound. Neurological examination, fluctuation of conscious level, and confusion are clinical presentation of hyperviscosity in case nodules, scar, and hair. Subcutaneous nodules are solid, raised bump on the skin. Scar tissue form as skin heal after an injury or keloid. It is called a keloid, is an abnormal scar that is thicker, different color and texture extend beyond the edge of the wound. Neurological examination, fluctuation of conscious level, and confusion are clinical presentation of hyperviscosity in cases of paraproteinemias and chronic myeloid leukemias when the patient presented with high count exceeding 100 cells per cubic millimeter. Isolated nerve pulses in a patient with acute leukemia are highly suspicious of neurological involvement or disease relapse. Peripheral neuropathy and long tract sign are well recognized complication of vitamin B12 deficiency. Examination of a chest. The superficial surface of all bones should be examined thoroughly by applying intermittent firm pressure with a fingertip to locate potential areas of disease. Increased rib or sternal tenderness is an important physical sign that is often ignored. Increased bone pain may be generalized as in leukemia Leukemia, sternal tenderness is characteristic and pathognomonic feature in acute leukemia. Or spotty, as in plasma cell myeloma or metastatic tumors. Examination of the abdomen is essential section in physical examination in hematology. Hepatic and or splenic enlargement must be record extent of liver or spleen enlargement as maximum distance palpable from the lower costal margin. During examination of the abdomen must be no areas of the abdomen used for descriptive and clinical purposes. 4-quadrant abdomen is divided by a longitudinal line and a vertical line crossing umbilicus into 4 quadrants. Right upper quadrant and left upper quadrant, right lower quadrant and left lower quadrant, and divided into 9 regions. Abdomen is divided into upper, middle, and lower abdomen by 2 horizontal lines, subcostal and interiliac line, and then further subdivided by 2 vertical lines passing from mid-clavicular point above to the mid-inguinal point below. And these upper parts of the upper regions of the abdomen or upper part, right hypochondrial region, epigastric region, and the left hypochondrial region. And the middle regions, right lumbar region, umbilical region, and left lumbar region. Right iliac region and the hypogastric region, left iliac region, this is the lower parts and lower regions of the abdomen. Abdominal examination consisted of inspection, palpation, percussion, and auscultation. Inspection of the abdomen, as shown in this figure, must be fulfill these items and show normal and abnormal parts or abnormal configuration. Shape of the abdomen, it is normally scaphoid shape. When diffuse abdominal enlargement, it is mean chronic increase in intra-abdominal pressure. Subcostal angle, it is normally acute. When it is wide subcostal angle, it is mean increase in intra-abdominal enlargement in case of organomegaly, ascites, and so on. Divarication of the recti, it is normally absent due to strong abdominal muscle. When weakness of this abdominal muscle lead to divarication of the recti in cases of chronic increase in intra-abdominal pressure in ascites or organomegaly and so on. Umbilicus, it is normally inverted. It is normally inverted and midway between the Zephyr sternum and Sem5 pubis. When shifted up or down, it is mean is abnormality, and when inverted, it is mean abnormality. For example, chronic increase in intra-abdominal pressure in ascites and organomegaly. Suprapubic hair distribution, it is give me knowledge about feminine distribution or masculine distribution and steroid or disease chemotherapy induced patient received chemotherapy and so on. Skin give me skin examination in abdomen give me more information about dilated veins and the bleeding disorder signs in the form of petechiae, purpura, and ecchymosis, and abdominal wall edema, and scars of previous operation, and so on. Movement of the abdomen is normally when this movement is restricted, it is mean there is acute abdomen or pain in the abdomen, and hernial orifices in the form of epigastric region and umbilical region and inguinal region. When examined while the patient is standing, it is to denote if presence of hernia or not, and must be examined genitalia, presence of testicular masses, and so on. Palpation of the abdomen, superficial palpation to detect tenderness, superficial masses, deep palpation to palpate abdominal organs, as spleen and liver. Splenomegaly is defined as enlargement of the abdomen of the spleen, measured by size or weight. In the past, splenomegaly was a clinical finding, but in recent years, imaging studies have also helped to assess for or confirm mild splenomegaly, which can't be assessed by clinical examination. The spleen is a functionally diverse organ with active roles in immune surveillance and hematopoiesis. Spleen, it lies within the left upper quadrant of the peritoneal cavity and abuts ribs 9 to 11 and the stomach, left kidney, splenic flexure of the colon, and the tail of the pancreas. A normal spleen weighs 150 grams and is approximately 11 centimeters in craniocaudal length. The normal spleen is usually not palpable, although it can sometimes be palpated in adolescents and individuals with a slender belt. This radiology showing positron emission tomography scanning, it is called PET-CT. This PET-CT showing enlargement of the spleen, and after splenectomy of this case, it is diagnosed as diffuse large non-Hodgkin lymphoma. Diffuse large non-Hodgkin lymphoma. Diffuse large B non-Hodgkin lymphoma. It is one type of non-Hodgkin lymphoma. Splenomegaly direction and degree of enlargement as shown in this figure. Grade 0, it is normal spleen. It is impalpable spleen. Grade 1 spleen palpable only on deep inspiration. Grade 2 spleen palpable on mid-clavicular line, halfway between the umbilicus and the costal margin. Grade 3, the spleen expanded one toward the umbilicus. Grade 4, the spleen goes past the umbilicus. Grade 4, the spleen expanded toward the symphysis pubis. This show mild, moderate, and huge spleen. Concluded this grades into mild, moderate, and huge. Mild, the lower part of the spleen is felt below the lower costal margin, not exceed a midway between costal margin and the umbilicus. Moderate, the lower part is down to the umbilicus, 4 to 8 centimeters. Huge, the lower part is beyond the level of the umbilicus, as also shown in the under diagram. The landmark for Trops area and the area to percast to elicit Castle signs, which is dull Trops area. It is imagining area, which is a rectangular area. The anatomy of this area, it is lies between 9, 10, and 11 reps in anterior axillary line, and 6 and 8 reps in mid clavicular line, and it is directed. It is resonant Trops area, and when this area is dullness in this Trops area, it is mean abnormality. It is causes of dullness of Trops area: full stomach, cancer stomach, left basal pleural effusion, pericardial effusion, ascites, tumor, pregnancy, enlarged left liver lobe, splenomegaly, cancer pancreas, situs inversus totalis. The causes of resonant of Trops area: dilated stomach, left basal lung collapse, pneumonectomy, pneumoperitoneum, shrunken liver, and splenectomy. Characters and document of the spleen when present. Spleen is intra-abdominal organ in the left hypochondrium. The size according to grades or degrees by mild or moderate or huge. Moves up and down with respiration. The direction of the mass is down and to the right. Hand can't reach the upper border, as you can't insinuate hand between the costal margin and the organ. Dull on percussion, and its dullness is continuous with Trops area dullness. Notch may be palpable in anteromedial aspect in cases of huge splenomegaly in case of bilharziasis. Doesn't fill and can't be pushed into the renal angle. No posterior ballotment. Causes of splenomegaly, which is important topics you must know. Hematological causes: chronic myeloid leukemia, chronic lymphocytic leukemia, acute leukemia, lymphoma, primary myelofibrosis, polycythemia rubra vera, hairy cell leukemia, thalassemia major or intermediate, sickle cell anemia before splenic infarction, hemolytic anemia, megaloblastic anemia. Systemic diseases: collagen diseases, systemic lupus erythematosus, rheumatoid arthritis, Feltes syndrome, portal hypertension, hepatic, portal and splenic vein thrombosis, infection, acute septicemia, bacterial endocarditis, typhoid, infectious mononucleosis, chronic tuberculosis, brucellosis and syphilis, malaria and leishmaniasis and schistosomiasis, metabolic diseases, Cushing's disease, sarcoidosis and amyloidosis. This important message you must know, it is important in exam. Potential causes of massive splenomegaly in chronic myeloid leukemia, primary myelofibrosis, chronic lymphocytic leukemia, lymphoma, thalassemia major or intermediate, hairy cell leukemia, amyloidosis, Cushing's disease, malaria, leishmaniasis, schistosomiasis in chronic hepatosplenic bilharzisis third stage. How to comment on hepatomegaly? The liver is present in right hypochondrial region. The size composed of left lobe and right lobe. Left lobe sized by patient and breadth, and right lobe by costal margin, under costal margin. Finger breadth or centimeter in midline below the Zipf sternum for the left lobe and below the right costal margin for right lobe. Border either rounded border or sharp border. Surface either smooth surface or irregular surface in malignancy. Consistency either soft or firm or hard in malignancy as hepatocellular carcinoma. Tenderness either no tenderness or presence of tenderness in case of congestion or infection as hepatitis. Causes of hepatomegaly in the form of hematological causes as leukemia and lymphomas, hemolytic anemias, thalassemias, myeloproliferative neoplasm as polycythemia rubra vera and myelofibrosis, malignancies, primary tumors as hepatocellular carcinoma or secondaries, collagen diseases, metabolic diseases as fatty liver, diabetes mellitus, obesity, alcoholism, malnutrition, lipid storage disease, glycogen storage disease, amyloidosis, and sarcoidosis. Infection as viral hepatitis, other virus, Epstein-Barr virus, infectious mononucleosis, cytomegalovirus, bacteria as byemic abscess, tuberculosis, and brucellosis. Parasitic as bilharziasis, amoeba, leishmaniasis, and malaria. Spirochetal in syphilis, third stage, rickettsial as in typhus. Portal hypertension and cholestasis, acromegaly. Lymph node examination. Lymphoid organ consists of primary lymphoid tissue and secondary lymphoid tissue. Lymphocyte develop in primary lymphoid tissue, it is bone marrow and thymus, and circulate toward secondary lymphoid tissue, which is lymph node and spleen, and the mucosa associated lymphoid tissue. This diagram showing distribution of lymphoid organs, tonsils and adenoids, cervical lymph node, lymphatic vessels, thymus, and lymph node, axillary lymph nodes, and spleen, Byers patch of the intestine, appendix, bone marrow, and bilateral inguinal lymph node and lymphatic vessels. This definition is important in hematology. You must know the lymph nodes are distributed all over the body. Normal lymph nodes are usually less than 1 centimeter in diameter and tend to be larger in adolescent than later in life. Lymph nodes play an important part in the body's defense against infection. In adult, lymph nodes normally are not palpable except for the inguinal region, where small nodes up to 1.5 centimeter may be felt. Lymphadenopathy is a term mean disease of the lymph node either in the enlargement in size or the consistency, serves an excellent clue to the underlying pathology and etiology. How about lymph node examination, inspection, and palpation? Single site of this lymph node, what is the group, either peripheral group or internal group. Peripheral group in the form of cervical group, axillary group, epitracheal group, inguinal group, epithelial group, and so on. Single or multiple, one group, one lymph node, or multiple lymph nodes, one group or multiple groups. size of this lymph node by centimeter. Consistency either soft as lobule of the ear, hard as maxilla of the face, firm as tip of the nose. Discrete or matted. Discrete, it is mean only one group, not united to each other. Matted together, it is coalesced with each other. Tender or not, by pressure on this lymph node, the patient feel pain. Mobile or fixed, it is mean direction of this lymph node up and down, right and left. When restriction of this mobility, it is fixed to the underlying structure or the skin overlying. And pressure on surrounding structure, it is presence of pressure, it is denote signs and symptoms on the patient. For example, when presence on huge inguinal lymph nodes, bilateral, patient presented with edema lower limb and dilated lower limb veins, and also of presence of axillary lymph node enlargement, patient presented with bilateral edema in both upper limb and dilated veins on both upper limb. This diagram showing lymph node group, you must know, and you must know how to examine this lymph node group in clinical training, inshallah. It is divided into cervical group and clavicular group and mediastinal group, axillary group, epitracheal and abdominal and inguinal and popliteal. Cervical group, right and left, periauricular, postauricular, occipital, submental, submandibular, upper and lower cervical. Clavicular group, also right and left, supraclavicular group and infraclavicular group. Mediastinal group, only it is mediastinal, not right or left. Axillary group, it is right and left group. It is 5 group. Anterior group, pectoral, related to pectoralis major muscle. Lateral group, it is humeral group, it is related to humerus bone. And posterior group, related to subscapular group. And the central group in the floor of the axilla. Epitracheal group, it is right and left. Abdominal group, it is diagnosed by imaging technique, except the patient is very thin and it is huge. Inguinal group and popliteal group, abdominal group in the form of para-aortic and common iliac and external iliac group. Right inguinal group, it is inguinal and femoral group, and right popliteal group and left popliteal group. The cause of lymphadenopathy is this essential component in hematology. You must know this slide perfectly. Cause of lymphadenopathy in the form of localized causes and generalized causes, and sometimes the patient presented localized and then generalized. For example, Hodgkin lymphoma. Localized group, lymph node draining aseptic focus, non-specific inflammation, cervical, tonsillitis and scalp infection, axillary infection in fingers, and inguinal infection in lower limb, periauricular in otitis media, metastasis from the carcinoma or other throat tumors, hilar in bronchogenic carcinoma, right supraclavicular from hepatocellular carcinoma and mediastinum, lung or esophagus, left supraclavicular group, it is called the Virchow group. The most common cause of enlargement of this left supraclavicular group is abdominal malignancy as GIT, stomach, gallbladder, pancreas, and also the kidneys and testicles, ovaries, and prostate. Cervical group, the most common cause of enlargement and metastasis from thyroid, tongue, and parotid. Systemic infection, either viral in viral hepatitis, right supraclavicular lymph node enlargement, bacterial in tuberculosis and plague, and protozoal filarial infection, inguinal lymph nodes, and spirochetal lead to primary chancre, primary syphilis, draining chancre, and generalized lymphadenopathy may start as localized lymph node as in Hodgkin lymphoma, then generalized. Generalized group, generalized causes of enlargement of lymphadenopathy, infection as viral infectious meningococcus, cytomegalovirus, human immunodeficiency virus causing AIDS syndrome, bacterial as tuberculosis and brucellosis, spirochetal as secondary syphilis, protozoal as toxoplasmosis and Kala-Azar, fungal as in histoplasmosis, leukemias as chronic lymphocytic leukemia, acute lymphoblastic leukemia, and acute myeloid leukemia, especially M4-5. Lymphomas as Hodgkin disease, non-Hodgkin lymphoma, metastatic carcinoma, metabolic as Koshar and Niemann-Beck disease, and collagen disease in rheumatoid arthritis, systemic lupus erythematosus, Feltes syndrome, infiltration sarcoidosis, and drugs by phenytoin, extramedullary hematopoiesis in thalassemia and myelofibrosis. These references or further reading to fulfill the outcomes intern ILOs of these topics, and when there is any question in these topics, you can ask me at any time by mobile or contact as presented before. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.